Okay, so thank you, Mr. Chair. Greetings to the audience. I'm going to be talking about management of stage 3. Evidence and experience so far may overlap somewhat with the previous speaker's talk, which I just got the tail end of. Thanks to AstraZeneca, which has made this possible. These are my disclosures. I'm going to just be talking a little bit about stage 3, definition, incidence, and treatment, the concept of the immune checkpoint inhibitor, the 5-year update of the Pacific, the role of the MDT, the use of development in sequential versus concurrent, and in cases with the druggable driver mutation, and a little bit about the management of pneumonitis. Now, this audience is probably no stranger to the staging of non-small cell lung cancer. This staging system seems to be updated about every 2 years. I don't know when they're going to stop, but they seem to be keeping on going and getting more and more refined categories. If you look at the stage 3, for example, at the combinations of T and N and so on, that there's 39 different combinations of T and N. So I'm certainly not going to go into all of it, but they've been subcategorized into 3 broad categories of A, B, and C, of increasing extent and severity and worse prognosis. Pragmatically, it's not the early resectable ones, it's not the widely metastatic ones, it's those that are in between. Most of them have mediastinal nodes, either on the same side or the other side of the tumor, or both. Some of them have supraclavicular nodes. The general idea is that you can encompass this within a radiation field similar to the limited disease small cell concept. We have now excluded the positive pleural effusions a long time ago outside the stage 3 category. So that's stage 3. It's a very significant public health problem right around the world. There's 25% at least of non-small cell lung cancer is stage 3. And the long-term survival is probably no better than about 20% at best. There was an improvement in survival with the addition of chemotherapy, and we learned that a long time ago. We saw that it was even better if you could give concurrent chemotherapy and not just sequential chemotherapy. But the ESMO, for example, understands that not everybody can have combined concurrent chemotherapy, that some people are elderly, some people are frail, some people have larger tumors, and they may be suitable for the sequential approach, which is maybe more old-fashioned, but is certainly less toxic. And I would want to make a point that the original Dillman study, which really was one of the major studies that changed our practice here towards the addition of chemotherapy, showed a really rather large improvement in median survival from about just under 10 to just under 14 months, and a tail on the curve, which seemed to push the cure rate up to almost 20% from sort of 5 to 7%. Now, sequential chemoradiation is more acceptable to some people because it's less toxic, and you can see this in the incidence of grade 3-4 esophagitis, which in sequential is only about 4%, whereas it goes up to about 20 to 40% with concurrent. Now, concurrent is a better outcome, but there's a bit of suffering with that, with respect to the toxicity. So patients have to be robust. They have to be able to look after themselves. You have to manage the esophagitis. Sometimes it requires hospital admission or certainly IV fluids, when they're coming to get radiotherapy every day. So it's not trivial. What do you get, from this all now? Well, recent meta-analysis in 2010, about 11% 5-year survival with sequential, and about a 15% survival with concurrent 5 years. That's 5-year survivorship. So it's not acceptable, even if it's, certainly better than radiation alone, it's still not acceptable. So we have tried many things over the last 30 years, including consolidation chemotherapy, which didn't work. Here's platinum-based chemotherapy consolidation. There was consolidation with docetaxel, that didn't work either. There was pushing up the radiation dose, that didn't work. Actually, it's worse if you push the radiation from 60 up to 74. There was vaccinations that didn't work with various preparations. There was changing to different chemos like pemetrexed. Pemetrexed is less toxic and it's equivalent, but it's not better. It's certainly an option, but it's not better. And so until recently, these people had the chemoradiation, either sequential or concurrent. And then it was, well, we're just going to keep you under surveillance and cross our fingers that you might be one of the minority that's lucky. But, clearly, it's not satisfactory because most of these people recurred. Now, the surgeons obviously have tried to do their bit here, and so this was exemplified in this seminal study, the intergroup 0139, which randomized people up front to chemoradiation followed by surgery or chemoradiation to complete radiation. And so after 45 gray and 2 cycles of cisplatin etoposide, they were reassessed, hit the pause button, CT scan. Those who were randomized to surgery went to surgery. Those who were randomized to completion radiation went there. And then they all finished off with a bit of chemotherapy, which certainly not everybody could get, by the way. And this is the result. The result is actually that there's, overall no improvement in survival. Now, the story is a little bit complicated because these curves do cross each other. And so an exploratory analysis was undertaken to look at, hypothetically, this is real data in yellow, but the blue is hypothetical. The people who got chemoradiation, if they had been able to get a lobectomy, and that's a supposition, they might have done better getting actually a lobectomy. If they had to have a pneumonectomy, which is, the blue curve here, they never got a pneumonectomy, but that's the chemoradiation. But the yellow curve actually did get a pneumonectomy, but they try to match the people. They actually did worse. So it seems that pneumonectomy is very dangerous in the context of chemoradiation because, of course, the entire cardiac output now goes into one lung. It's partially been irradiated by the spillover, and it doesn't come out. These people are teetering on the brink of pulmonary edema, and I've seen a couple die like that, actually. But if you can get away with a lobectomy, there is an argument for doing it. So I think, we have to be able to understand and talk to our colleagues in surgery here because we have to work with them. There is no doubt that if you do surgery, you have a lower incidence of local failure, local only failure. But most of the relapse is systemic. And unfortunately, the surgery, no matter how technically expert, does not protect you from metastatic failure. Even single station N2, and the best of the best, which is upper mediastinal single station N2, you're really only pushing 40 to 50% 5-year survival. And now we may say, well, that's not bad. It's not bad for lung cancer. But if this were breast cancer, it'd be completely unacceptable. And it is unacceptable today if we can do better. And all of this is illustrated by a very large study out of South Korea, which took 570 patients with 3A disease, most of them 3/4 were single station N2. And they try modality therapy, chemoradiation and surgery. You can see the dynamics of the recurrence here. Up top here, it's the distant recurrence. At the bottom, it's local failure. You can clearly see that most of the recurrence is in fact systemic. The 5-year disease-free survival was only 30%. That means 70% of people had failed. And if you look at the failures, most of them are distant. Unfortunately, no matter how good the surgery, most of these people have micrometastatic disease and cannot be helped by surgery. So the surgery, although it's good and it helps local control, as far as the metastatic disease is concerned, in most of these people, it's like closing the barn door after the horse has already escaped. So we have to think differently. So thinking differently is about immunity. So we know most people with lung cancer, it's due to exposure to tobacco and other mutagens. We know that most of these lung cancers are very mutagenic, and we know that mutations may be antigenic. So we have the cancer immunity cycle here, whereby tumors are turning over. There's antigens that are shed into the tumor milieu. They're picked up in some cases by dendritic cells. They're trafficked to the local lymph node. There's a checkpoint there called the CTLA4, which is an inhibitory checkpoint. And at that point, that may be the end of the immune response. However, if they can circumvent that checkpoint, they get back, they clonally expand, get back into the circulation, they go to the tumor, where there's another checkpoint called PD-1, PD-L1, which is also inhibitory. So these checkpoints were discovered by these two individuals, James Allison and Tasuku Honjo, who rightfully got the Nobel Prize. Now, radiation can manipulate the immune system, both for good and for bad. Most of it, or many of the mechanisms, seem to help the immune system, and they include secretion of danger signals and cytokines, so-called immunogenic cell death, explosion of the tumor, shedding of antigens that's increased, trafficking of immune and inflammatory cells into the tumor that's enhanced. But unfortunately, there's also upregulation of PD-L1, which is, as we've seen, is a negative regulator of the immune system. Now, chemotherapy can help in addition by secreting a variety of proteins or upregulating things such as calretinin or pushing ATP into the tumor milieu. This manipulates the dendritic cells and makes them more competent to express and gather the antigens and show it to the lymphocytes. The problem, of course, is this elevated PD-L1. You have to block it in some way. You have to inhibit it. And so fortunately, we have durvalumab, which is an anti-PD-L1 antibody, and that can block this negative signal. It's a kind of a negative of a negative so that it disinhibits the T cells, both at the level of the interaction between the tumor cell and the T cell, but also between the T cell and the macrophages or the dendritic cells. So all of these concepts were amalgamated together in the Pacific study, which the previous speaker has described. So I'm not going to dwell too long on this, but this was a study of good performance status patients, had to have combined concurrent chemoradiation. They could have had a few cycles up front, but they had to have platinum-based chemotherapy during the radiation and not afterwards. They were reassessed. If they had not progressed, they were then randomized 2-to-1 to 10 mg per kg of durvalumab every 2 weeks compared to placebo. So this is a double-blind, placebo-controlled trial, the gold standard in medicine. The co-primary outputs were PFS and overall survival, and the PFS assessed by a blinded review committee, and multiple secondary endpoints, including some translational science. This is the spectrum of chemotherapy that was permitted. It's either carbo or cisplatin-based, either Vincas or taxanes, or most people got etoposide. This has now been published in the Journal of Clinical Oncology, and as you've seen, these curves split early, they stay separate, and we now have data out to 5 years, which indicates that the protection from death is about 10% of people. The real protection from cancer can be seen here in this curve, where it goes up from 19 to 33%. That's about 1 in 6, 1 in 7 people have protection from cancer. And the very interesting thing is that these curves are sort of parallel by this stage, and possibly this represents cure. You see a massive protection from systemic disease. These, again, this is time to distant metastases. The curves separate early, they stay apart, they widen, and even by 16 months, 5 years, they are considerably apart by about 14%. So we think this 14% of people who are protected from distant recurrence may be the people who are cured. This seems to help both non-smokers and smokers, and it may help people with EGFR mutation positive status, which is a relatively small number of people, so it's not a statistically secure conclusion, but it looks like the evidence is that it probably does. And this is the progression-free survival, where you can see that the data point there is to the left of the unity line, and in fact that's also true for the never smokers, which was a little bit of a surprise. And we know that many of these EGFR patients are never smokers. There was a concern initially about PD-L1 negative patients. Now that was not a pre-planned analysis, and what we see is the point estimate here for survival is very, very, very close to the unity line. There was some worry that it was to the right, but it seems to be now on the unity line. This study was not powered around PD-L1 negativity, and in fact, it wasn't one of the pre-agreed on analyses, which was more than or less than 25% PD-L1, which clearly benefited both of those categories. But if you look at the progression-free survival for the PD-L1 negative, the point estimate is clearly to the left of the midline. But as I said, this is a relatively small number of people, so the confidence intervals are wide. And so there's some uncertainty about that, but this study wasn't powered around that. What we know actually is that if you stick the needle this way or that way, you can get a different PD-L1 result. We know that radiation causes an increase in PD-L1 expression, and this was baseline PD-L1 done before radiation. So maybe, the PD-L1 measurement is not even reliable. And in Canada and in the United States, we have no problem in putting any PD-L1 patient, offering them durvalumab after chemoradiation. We have no problem. In Canada, we're very careful about money. We do not throw money around unnecessarily, and we are quite happy to put PD-L1 negative patients on. What we do know is that patients who were exposed to cisplatin as opposed to carboplatin, cisplatin seem to get a bit of a better benefit. People who put on early within 14 days as opposed to day 15 to 42 seem to have a substantially improved benefit, but certainly the others benefited as well. So we tell people, we're going to be offering you immune therapy afterwards, so it doesn't come as a shock and they want to, discuss it with their family. We arrange the CT scan so that it's done in the week after the end of the radiation, and we see them within 2 weeks. And we pre-book a slot for durvalumab in the chemotherapy suite. Now, some people cannot manage this in 2 weeks. Some people are beaten up by chemoradiation, and they need more time to recover. So not everybody can be put on in 2 weeks. But if you can, it seems to be better. We know that the tumor continues to shrink more on the durvalumab arm if you look at the response rate. And we know that that's a good thing with respect to symptoms. There is, certainly radiation pneumonitis, whether you're on placebo or durvalumab, there is radiation pneumonitis. You can't escape the risk of radiation pneumonitis. It's a little bit enhanced on durvalumab, and that may be a bit of durvalumab pneumonitis. Sometimes it's very difficult to tell the difference. But in general, it's mild. I'm not saying it can't be severe. It can, but it's very uncommon. And you see some other, autoimmune side effects as hypothyroidism, which you should keep an eye out for, rash, and so on and so forth, which is generally mild and easy to manage. There is the pneumonitis risk, which goes up from about 6.8 to about 10.7%. But if you look at the grade 3 or 4, the grade 3 or 4 is actually not increased on the durvalumab arm. Leading to discontinuation, well, there's maybe 1 in 20 people it has to be discontinued because of the durvalumab. But considering the magnitude of benefit, considering that people discontinue anyway because of chemo and radiation, this is a good deal. This is one of the best deals in oncology in terms of risk benefit. Now, you get protection here from systemic disease. This has been discussed by a previous speaker, so I won't dwell on it. But what we see in that intergroup study, protection, local control, sure, from surgery, but no protection from systemic disease. In the Pacific study, protection both locally, regionally, and systemically. And the systemic protection, you reduce the risk of metastasis by between a third and a half of those people. So, for example, brain metastases down from 12 to 6%. That's a massive benefit. You know what brain metastases means. Okay, liver down by more than half, adrenal and bone. So what we're concluding here is that, as the previous speaker said, there's a big improvement in median overall survival from about 29 to 47 months. There's about an extra year of PFS. But in fact, there's more tumor control in terms of disease control rate is better on the durvalumab. The toxicity is generally mild and manageable, but you have to be aware of how to deal with it. But it does look like the consolidation maintenance immunotherapy immune checkpoint inhibitor with durvalumab has likely improved the cure rate, given that those curves appear to be parallel and staying apart at 5 years. Interest of time, I'll just show there's a massive research project going on with early stage resectable, unresectable patients, local, regional, and metastatic patients with durvalumab. It's a massive ongoing research project. Just want to talk a little bit about real world evidence. This is a study done in Europe and Australia where patients with a reasonably good performance status were offered chemoradiation concurrent or sequential and were then offered durvalumab. I'd say here that about 15% of patients were treated with sequential disease. This imitates certainly my practice. We can't get everybody on concurrent. Who can't get concurrent? Well, it's older people and people with bigger tumors. So that's not a surprise that some people need sequential. In this patient population, which is pragmatic, just like mine, there's a considerable burden of comorbidity, hypertension, COPD, diabetes, cardiovascular disease, obesity, etc. The progression-free survival was not rigorously assessed, and so actually was in fact a bit longer, somewhat longer than in the Pacific, but it certainly wasn't less. Okay. The point I just want to draw your attention here to the survival outcome. Actually, sorry, this is PFS data in sequential versus concurrent, and you can see that it's just about the same. So the sequential is reasonable, in the right kind of patient. The older, frailer, bigger tumor, the sequential is okay if you have to do it. And the pneumonitis rate and the toxicity rate in this study was about the same as in the Pacific study. So just a couple of case reports real quick. 75-year-old man had a stroke, been worked up, found to have a tumor there. Good pickup, I think, on the CT scan. There's an N2 node. There's the PET scan showing the primary, the hilum, and the N2 node. It's biopsied. It's a very poorly differentiated, you don't know if it's an adeno or a squamous, but very poorly differentiated, but strongly positive. This guy's a smoker, PD-L1 more than 50%. Next generation sequencing, no mutation was detected. And we said to him up front, we think you're okay for chemoradiation, but we use vinblastine. We didn't have a topicide because of a shortage, but we said we're going to be offering you durvalumab afterwards. There's the post-radiation CT scan. This gentleman is accepting the durvalumab, and here he has 12 months of durvalumab, day 1, day 15 at that time, although you can give it monthly now, actually, but this gentleman had 24 infusions of durvalumab. He went through it, no problem. About 3 years after the start of his treatment, he started to see flashing lights in his visual field. And in fact, he has a brain metastasis there, and you can see it on the MR and on the CT scan. This was solitary. So we actually referred him to neurosurgery. He had it excised. It's now PD-1 weakly positive. And in fact, there's P53 mutations now detected. We wondered, is this a different cancer? We searched him from head to foot. There's no evidence of anything outside the brain. And so we think this is just a recurrence. We think it's in fact a late recurrence. And we think, we wondered, what should we do? Should we radiate his whole brain because of the cognitive effects of that? So we said, no, we're just going to give him stereotactic radiation to the tumor cavity. And we think, being over 75, you benefit over 70 just as much as you do under 70. So age should not be a barrier to durvalumab. We think this is one of these gentlemen who never had complete protection in his brain, but he only had a solitary tumor. He didn't have multiple, and it was late. It was delayed. So we do think, given there's no other evidence of recurrence, solitary brain met, resected, now possibly cured again, we think on balance was a good thing that we gave this gentleman durvalumab. So this is not a perfect case with no recurrence. This is the kind of reality. People will still relapse, but I think in this case, it was probably delayed. Critical role of the MDT, just briefly, we know that in the COVID situation, there's fewer people who are discussed on MDT. This is not a good thing. This is some data from Philadelphia showing that you can use telemedicine not only to communicate with your colleagues, but also to communicate with patients. That might help this situation. We know that there was no increase in the time to start radiation or the time to start chemotherapy, but there was a little bit of maybe about a week's delay in starting surgery. So we think that, surgical patients may not be best suited for telemedicine, but we think that people who are going to get radiation or systemic treatment, you can employ technology to get around this COVID kind of situation. Now, the MDT is critically important. You should have a core MDT, if at all possible, with the radiation therapist, the thoracic surgeon, the medical oncologist, the pulmonologist, if possible, the radiologist, critical, the pathologist, and then maybe the research people, maybe the supportive care people. Pharmacists, I find, are very helpful. This is the core MDT. You can make it more sophisticated with immunotherapy people. You can make it the genomic, ad board, MDT. You can make it an advanced radiotherapy planning MDT. You can have a national MDT or regional MDTs. You can make it more and more sophisticated. But the key thing is, at the very least, you should have a core MDT. And we know that there are complex issues here of diagnosis, staging, investigations, molecular, and so on, immunostaining, biomarkers, as well as therapy plans, this very heterogeneous disease. These people are markedly benefited by having an MDT. Why? Because they're exposed to specialists who understand these issues. We cannot expect community oncologists to know about all of these things because it's continually being updated, and they have to treat everything. We know that there are huge countries in the world. Canada is one of them. India is another. We don't want just the people in the cities, to have the benefit of these new drugs. We want to democratize it so that everybody can benefit. And so we need to have a system, and technology can help you do this. There is more effective decision-making in an MDT. So this is exemplified here by the SEER data from 45,000 patients in the United States. Only 23% had guideline concordant treatment, and they did better. The other 77% of people had non-concordant treatment, and their hazard ratio for death was 1.42, nearly 50% higher risk of death if you don't have concordant treatment, and you are less likely to have guideline concordant treatment if you don't have an MDT. What about driver mutations? I'll just show here, there's a whole raft that you know about: KRAS, BRAF, MET14 skipping. We know that there is a likelihood that they will benefit from immune therapy, obviously targeted, but immune therapy. HER2 and EGFR mutations, there is some evidence that some people, but not everybody, will benefit from immune therapy. ALK, ROS, and RET? Probably not. This data from IMpower 150 shows an improved response rate, a better PFS, and in fact, a better overall survival from the addition of atezolizumab to bevacizumab, carboplatin, paclitaxel. You can see the ABCP in blue versus the BCP in red, and the hazard ratio for survival is 0.6. Now, I grant you there were not that many people with EGFR, but it does seem that the majority of the data here indicates that they can be PD-L1 positive. They could be smokers. It doesn't stop you getting EGFR mutated. And the Pacific data here seems to show that there is probably a benefit in these people. So we have no problem in Canada where we have to watch our money. We have no problem giving these people a PD-L1, anti-PD-L1 drug. So there's the LAURA study, which is looking at osimertinib versus placebo in the stage 3 patients EGFR mutated. We don't have the outcome data of this yet. That may change our practice. So this is an open question. Should they get osimertinib? Should they get nivolumab? It's an open question in my mind, and we will see what we will see. So finally, there's a 52-year-old female Filipino living in Canada. She has a lump in her neck. She's a never smoker. There's the lump in her neck. There's the hilar mass. There's the N2 node. There's the cytology biopsy showing a nice little gland there in the cytology specimen. It's TTF1 positive. The rest of the scanning is negative. The PD-L1 is 1 to 49, so it's actually positive. And in fact, she has a sensitizing EGFR mutation, but we are not funded to give osimertinib in this situation at the moment here in the stage 3 setting. There's her baseline chest X-ray, both the lateral and the PA. There's her CT PET scan, which clearly shows the disease in the chest as well as in the neck. She has 2 cycles of cisplatin etoposide and 60 gray and 30 fractions. It's well tolerated. And there's the post-CT staging. There's the pre-chest X-ray. There's the post-chest. Clearly better. It's not worse. She agrees to nivolumab. She has 2 cycles of nivolumab. She starts to get a cough. She starts to get a shorter breath. So we do a chest X-ray. We kind of start to see something here. We do a CT scan, and you see dense fibrotic reaction within the radiation field. Okay, this is probably radiation pneumonitis. You can't escape this risk, whether you get nivolumab or not. You're gonna suffer this risk. So we can't conclude that there's no contribution for nivolumab. So out of an abundance of caution, we hold the nivolumab. We gave her prednisone weaning over about 2 to 3 months. She started to feel better. We kept a very close eye on her. And here's her chest X-ray 3 months later. She says, I'm okay now. So we reintroduced the nivolumab. She's, after the 2 cycles, she's now had 8 cycles of nivolumab, further nivolumab without any problem. And her intention and our intention is to complete the 12 cycles. So just very briefly to show that for pneumonitis, the PD-L1 incidence appears to be a bit lower than the anti-PD-1 drug, and it's lower than the CTLA-4. So there is a school of thought that believes that the anti-PD-L1 immune checkpoint inhibitors have a lower rate of toxicity than the other types of immune checkpoint inhibitors. But it can still happen. You know how to deal with it. Grade 1, you're keeping a close eye on. Maybe you're carrying on, but you're keeping a close eye on it. Grade 2, you're into holding the immune drug. You're into oral steroids. Grade 3, you're into IV steroids. And grade 4, you're into hospital admission and maybe event. You don't want it to get to grade 4 or grade 3. You want to be onto it quickly. You want to stamp on it, take away the Durva or the Pembra, whatever you're doing, get them on some steroids, reassess. If they recover, you can reintroduce the immune drug, but do it carefully and cautiously. This has been reviewed very nicely in this publication. Anybody who wants these slides, I'm very happy for anybody to have them. Just ask the company. This is a good paper, very thorough analysis of radiation pneumonitis and or immune-related pneumonitis, because sometimes you can't tell the difference. You have to be very careful about the planning, the V20 and all that kind of stuff so that you don't excessively expose the normal lung fields to radiation damage. And you have to see, where is the pneumonitis? Is it in the field? Is it in the radiation field? Is it outside the radiation field? You have to make a judgment. If it's in the radiation field, it's probably at least predominantly due to the radiation rather than the immune drug. If it's predominantly outside the field or right across the lungs, it's probably the immune drug. If it's severe, by the way, don't reintroduce the immune drug. You can't take the radiation out. You can't take the cigarette damage out, but you can stop the immune. If it's severe, you have to stop the drug. But it's very rare that that happens, as we see from the specific study as we see from the real world evidence. Severe pneumonitis, grade 3-5, was very uncommon. But you will see, you know, certainly people with mild or moderate pneumonitis, and you have to know what to do. And with that, I thank you, Mr. Chairman, and thank the audience for their attention.